to get started. It's always a delight to introduce a speaker from within our group who is really as extraordinary as Stephen Coca. He was recruited to Sonic from Yale, where he had actually an illustrious career there as well, and he's been the Associate Chair for Clinical and Translational Research here, an Associate Professor of Medicine within the Division of Nephrology. And really, if you look at his CV, you'll see the myriad of publications and areas of interest in research that he's been involved in. He's been funded through NIH for about 10 years now or more at this point, and really is a leader in clinical research, which is, as I can attest to, is not as easy as area to move forward in. So I really applaud you for that. He's going to be speaking today to us on machine learning-enabled clinical diagnostic solutions for diabetes-related kidney disease, and we thank you again. Should we turn off?
No, keep them on.
Okay.
I think, yeah. You guys are awake. I'll try to keep you awake.
All right, I'll be awake. Don't worry.
Good to be here. I think last time I was here was like about 4.5 years ago when I was just arriving to Mount Sinai. So it's good to be back. I'll try to figure out this podium. I forgot my slide of answer. My disclosures, I'll let them be there for more than 3 seconds, but a lot of these are recent, keeps coming, especially with all the good data coming out, and now they want to figure out implementation. And the one that's most relevant is Renalytics, which I will talk about in the last 10 minutes and how this dovetails into the work I've been doing. So you'll see, and we'll talk about Kidneylntelx. So, my work has been using biomarkers. At Yale, initially was mostly AKI biomarkers, but AKI is difficult, timing is so dependent, and there's really no good therapies. And since 2012, I've really been focusing on CKD and DKD. And the way we've been using them is primarily conducting observational studies, and creating risk models, trying to predict outcomes, understanding mechanisms of disease. It's been fun, it gets you papers, gets you grants, but it's not changing anything in clinical practice, and it's kind of gnawed at me. And when I came to Sinai, I remember saying this in a talk 3 or 4 years ago. I said, I want to accomplish goals 1 and 2 that are coming up here, and if I don't, then fire me because this is going nowhere. One is to use some of this biomarker work to change the way we conduct randomized controlled trials. And in the middle part of the talk, I'll talk about how this actually plays out. And then this was my 10-year goal, maybe, to really bring this to clinical practice and change the way we care for patients. But I'm going to show you at the end through Renalytics and Kidneylntelx how this is going to happen in a movie theater coming to you in 2020. So really accelerated the timeline. If that thing's only going to stay in the corner, it's going to block my kidding. See, it's going to block my references. That's where I put all my references. Okay, good. All right, so you guys know diabetes causes about half of all, or associated with half of all end-stage kidney disease in the United States. Amazingly, in the United States, only about 40% of patients with stage 4 CKD even get referred to nephrologists, and about half of all patients start dialysis without having seen a nephrologist in the past year. I don't even know how that happens. It's pathetic, and it really led to the opportunity for what we're trying to do. Is that? That's what I'm saying. When you actually drill down, this study actually looked at the notes and the charts and the billing of primary care providers, and that's the red bars, what they were doing, whether they were even noting whether patients had CKD, and the green is the patient awareness of their stage, which obviously is going to be less than what the doctors notice. And again, it mimics almost what the referral patterns are. Only 50% of doctors are even reporting CKD stage 4 in their notes or in their billings, and then of course stages 1 through 3, it's absolutely miserable. Then we've got the converse problem with the staging, stage 3. Look, I pulled this from a person maybe 6 months ago in the science. 0.96, she's like a 77-year-old white female. And with the eGFR calculation, it puts her into a GFR 54, stage 3. And then how many patients, now, okay, you take away or not aware, now they're aware and they bring you their their Quest form, lab coat, whatever, and say, oh my God, I have stage 3, I'm gonna die! Because they equate it with cancers, right? And it's pathetic that we've done this, and this woman obviously is not ever, probably, unless a catastrophic black swan event happens, ever gonna need dialysis. And so our system, our current staging system, needs help. So stage 3, kidney disease, these were recent publications that showed, you know, what I'm saying. Stage 3A is here in green and 3B in blue, and you can see these are 0.00432. The probability of progressing ESRD is low. There's only a few percent that are going to progress. And this study from Scandinavia showed that even after 20 years of type 2 diabetes, less than 2% will develop end-stage kidney disease. So how do we predict who's going to progress? People have tried to do this. This was a post-hoc analysis of OnTarget and the Origin trials. 40,000 patients. They used all these variables to try to predict who's going to progress from early stages. And you can see the AUCs here, 0.67, 0.71, not great, and they tried different methods. So what do? We're using our standard labs. It's not really good enough. It's not working in real life. So can we add in biomarkers? So this is, again, has been the focus of my work. Cardiologists, look how much they've advanced in the last 15 years. They have all these mechanistic biomarkers that change clinical care in all these pathways, right? And what have we done in nephrology? eGFR and albuminuria, proteinuria. That's basically what we've used. It's what we've had approved. It's what we've had in our armamentarium. So there's been this whole explosion of biomarker research that really started with the motivation to change AKI. These markers get secreted into the urine, expressed in the tubules, etc., shed upon damage to various sites of the nephron. And so there's been thousands of publications now on these for AKI, and then some translation into CKD. And I'm only going to spend 2 minutes on the urinary biomarkers in CKD or PKD because, like Willie Sutton said, why do you rob the banks? You go where the money is. And the data here are not that supportive for this indication, but there's some subtleties. This is just one of the examples. The CRIC study, the largest cohort study of chronic kidney disease. Here are some of the classic kidney injury biomarkers. And sorry, this is also the busiest and most unreadable slide. I know you're not supposed to even apologize and just don't put the slide in. But KIM1, NGAL, NAG, and LFABP. Unadjusted hazard ratios were like 10, 15. But the story has been shown over and over again. Just for age, nothing, and demographics, nothing happens. But once you adjust it for eGFR and albuminuria, point estimates all went to 1 and confidence intervals crossed 1. And this is a summation of 25 minutes of another versions of talks I've given. These injury markers, whether we've studied in CRIC, ERIC, Pima Indians, the Accord, have shown signals unadjusted but do not provide utility above and beyond clinical variables. These other markers, there's more research going on and more needs to be done to determine whether they are going to add, including epidermal growth factor, MCP1, and the others. So we'll see. They're just not ready for prime time yet. So that's why we're going to move to the plasma biomarkers, because like I said, here's where the thrust of the data have come. So there's issues now. The urine was supposed to be the easy one, right? The urine creating the tubules and catching all right there proximal to the injury. With the blood, if you have cleared markers and you have low GFR, you get this confounding relationship. You know, urine again, it's right there bathing the tubules. Here, you're picking it up in the blood. So systemic inflammation or injury can be also causing release of the markers. And some have argued some of these markers are picking up still kidney disease, but then you're assuming, okay, then it gets taken up by the peritubular capillaries, put into circulation, and that's really what you're detecting. So there's a lot of leaps of faith there. These are some of the classes or groups of biomarkers that have been most studied in this setting. And for sake of time, again, because SUPAR, FGF23, and the angiogenesis markers have had results like this, even though there have been some prominent publications, they don't always work. I'll show you a summary landscape slide in the middle, but we're going to focus on the data for the TNF receptors and KIM1s. And I'll show you some data on these settings. Diabetes, and that's why you guys are especially interested. You know, you've got this diabetic milieu, all this insulin resistance and things going on. Subclinical inflammation, can we pick it up sooner before there's actual histopathologic injury and before there's overt kidney disease? Now, I'll talk about the TNF receptors. There's a lot of animal data, but I'm going to spend very little time on it. Kathleen Shustak from UPenn did this gene expression study in tissue from patients with CKD, and what she shows here is in the middle of this network, TNF, tumor necrosis factors in the middle. The TNF receptors are transmembrane proteins receptors that bind TNF alpha, and when TNFR1 is bound by TNF alpha, it induces necrosis and apoptosis pathways. R2, when it binds TNF alpha, stimulates primarily pro-inflammatory, pro-fibrotic pathways. And these receptors are present in the kidneys, and knockout models of these receptors have shown intrarenal inflammation and fibrosis to be markedly attenuated. And also treatment with TNF alpha antagonists reduces glomerulosclerosis and kidney disease in animals and very little human data. Now, again, how can we use them as markers? We did not discover these markers. The seminal publications came from the Joslin Diabetes Center, Andrei Kroluski's group, Monica Nisolas, and they showed this impressive risk stratification. Baseline GFR of 90, 12-year follow-up. If you're in the fourth quartile of TNFR1, look at this progression to ESRD. If you're in the fourth quartile without proteinuria, you still had much greater difference in progression, and we had adjusted hazard. Oh, this mouse is killing me. Adjusted hazard ratios of 7 for R1 and about 4 and 6 for R2 for progression. They just published this a few months ago in Nature Medicine. They actually measured 194 proteins. They used the SomaLogic aptamer-based chip. They measured a host of inflammatory biomarkers. And what you have, they used the Joslin cohorts. There's Joslin 1 and 2, and they also used the Pima Indian cohort. And what you see on the volcano plot is TNFR1 and R2 are the highest, the strongest, most associated markers with progression. And then look at also the top 3, 4, 5, and 6, other members of the receptor superfamily. So it's clearly a very relevant and prognostic pathway. And then they have some other chemokines and inflammatory markers. They call these 17 together this CRISP panel. It's the kidney inflammatory signature. So KIM1, I'm going to transition a second. Again, initially largely studied for, oh man, you're in my pacing pathway. Hey guys, by the way, interrupt me. It's really small here. KIM1 is primarily located in proximal tubular cells, released for tubular injury. Oh, my alignment's off. We studied it largely in AKI. Joe Bonventri's group at Brigham found it was a great marker for kidney tubular injury in animal models. I don't know what happened to my alignment here. I mentioned the AKI story doesn't work that well. Then they've been writing, well, it can enter the circulation. And they published this in 2014 in type 1 diabetes showing plasma KIM1. Again, small, so this is about 100 patients. Stratified 97, greater than 97, less than 97, associated with ESRD. And then Helen Looker, a year later, published this where they measured 207 plasma biomarkers of metabolites in patients with overt DKD. They all had GFR 30 to 60. Here's the volcano plot. We've got some filtration markers up here, beta-2 microglobulin, cystatin C. But again, TNF receptors, KIM1, rise to near the top as far as association. These are per log base 2, per doubling. So pretty good. So Bonventri, he doesn't like to acknowledge this paper. In 2012, I actually confronted him on it. But he says it's still the tubular injury and it's being taken up into the peritubular capillaries and systemic. But you know, KIM1 is actually TIM1 as well. They're homologous proteins. TIM1 is T cell immunoglobulin binding domain, protein 1, and it's on activated T cells and B cells. So maybe when we're running our plasma KIM1 assay, we're also picking up some subclinical inflammation. Yeah, I cut it out. We actually did some unbiased clustering analysis from other cohorts, and we showed that plasma KIM1 came off branch points with some of this 10-plex, 10 panel of interleukins. So I think there actually is some validity to the story. We've got to publish that. So how about, that's the biology, that was the Joslin data, etc. How have we used it? So we bought this instrument. I bought it at Yale in 2013, and then bought it when I came here in 2014. The mesoscale QuickPlex 120. You know, it's like a Luminex, except it's electrochemoluminescence technology. Allows multiple analytes for like 10 microliters. Awesome sensitivity, awesome linearity, such that two of the large consortium involved with ASSESS-AKI and the CKD Biomarker Consortium, after rigorous QC and comparison of the different platforms, including ELISA, SomaLogic, and Luminex, chose this as the platform of choice for measuring the biomarkers. So the Accord trial, you guys all remember it, published 2008, 2x2x2 factorial design. I got funding in 2012 to look at plasma and urinary biomarkers and how they relate to kidney outcomes in Accord. Here we did case control because it was so large, 10,000 patients. Around the same time, we also got access to the VA Nephron-D samples. You remember dual RAS blockade versus monotherapy in veterans with overt DKD. And here we got, you know, there were some with missing samples. It wasn't the focus, obviously, of the clinical trial, but we got 1156, and here's the outcomes. I'm not going to read it to you. So we published this 2 years ago. We actually thought these markers would have more prognostic performance in Accord because you already have a heavy albuminuria signal in Nephron-D. Because look, Accord had no albuminuria, normal GFR, and here you've got almost a gram and GFR 54. But per doubling in the two cohorts, they actually compared similarly on the point estimates. We adjusted for all these clinical variables. And then the fourth quartile versus the first, we actually got similar results to the Joslin Center on these. But what it really was involving was flipping, just putting these three together, which no one had really done. We were running this as a fourplex with IL-18, MC1, and YTL40 on urine, primarily for AKI. And when we said, let's just use the same plate on the plasma, we got this signal. And what I like to show here, it's not just an overall inflammatory signature, or it's not an overall decreased filtration of protein signature, because IL-18, MCP1, and YTL40 had no association. So it's really these three. So when we did that, we went to mesoscale and said, let's make a specific threeplex. We don't need KIM1 with these other markers that are not giving us signal.
What's the odds ratio
No, in Accord, I didn't define it here. In Accord, it was, yeah, I had it on this slide. In Accord, it was a sustained 40% decline in reaching GFR less than 60. In VA Nephron-D, we followed the overall parent study's definition of progression. So it depended where you started, 30 mils if you're above 60, and a 50% decline or ESRD if you're below, okay? So different outcomes, different phenotypes at baseline. So the things that bothered me, though, as Accord I mentioned, was case control. They had no albuminuria, normal GFR, and the Nephron-D was all overt DKD. And so when I came to Sinai, one of the great enticements was the biobank, right? They had all this blank plasma. There's over, I think, probably 60,000 patients enrolled now. all the benefits. We linked it to the USRDS database so we could ascertain all ESRD, whether or not they left New York or Mount Sinai. And what we did is we pulled another 1,000 with type 2 diabetes, and then I'll talk about this in the next section. This was for Girish Nadkarni's K23 grant, where he's using biomarkers to improve risk stratification in patients with the APOL1 high-risk genotype. Should have done better data cleaning before we pulled, but anyway, ended up with 871 usable, low albuminuria, GFR 68, and 121 had progression. By the way, this 40% decline, you might say, where is this? You know the trial used to do doubling of creatinine dialysis to death? FDA and National Kidney Foundation in 2014 said a valid surrogate, based upon this JAMA paper that looked at over 1 million patients in the CKD Prognosis Consortium, a valid surrogate is a 40% decline. Because a doubling creatinine, if you actually do the math, it's like a 57% decline. And so there was problems with event rates, so they say we can use this. So that's why, if you're wondering about the 40% decline. Followed up with 4.5 years. So we measured it on the specific 3-plex, and again, we're getting separation and good signal for progression here in BioMe. Adjusted for these clinical covariates, we're getting robust signals. And this is just the simple, overall, there was 14% that had progression. If you had 0, 1, 2, or 3 biomarkers elevated, you can see this nice dose response in your rate of progression. And we'll talk about why we need to focus on these patients in clinical trials. So I mentioned the APOL1 story. I don't know how familiar you guys are. I'm just going to have one slide quickly. Western Africa, people in Western Africa who had mutations in the APOL1 gene are protected against African sleeping sickness. Okay? But study, why does this go backwards? But studies including this New England Journal paper showed, and several others from various investigators, that if you have 2 copies of the variants, you have a much greater risk of progression. And this has really been some of the explanation that has emerged over the last 10 years for the disparity of risk for African Americans developing end-stage kidney disease. So if you have 2 risk copies, you have a 10% lifetime risk. Girish looked at some GFR slopes in BioMe, whether they had, and these are all with the high-risk genotype. But what you can notice here is, yeah, that's a lifetime risk, but what happens in the immediate 5, 10, do we think of everything on lifetime risk? People want to know what's going to happen in a more proximal time frame. And then only 20% over all these years actually had rapid progression. So 80% are not progressing. So again, that was the motivation for his grant, and we applied aim 2 was to apply these biomarkers, and aim 3 was to use machine learning, which I'll talk about in the last half of the talk. And we published this last year, TNF receptors in KIM1, again, risk stratifying these patients with African Americans with APOL1 high-risk genotype for progression. So it's not diabetes, about 20% had diabetes or 18%. But it's showing another use case for these markers. You will note, however, the point estimates were much weaker than what we saw in the diabetics, about 1/3 as strong. Here we made this simple plot again, just 0, 1, or 2, we collapsed. It was similar, all 3 biomarkers elevated. You see this nice gradation of risk for developing the GFR decline over the 5-year time frame. Just going to show you just quickly the robustness of these. With Chirag Parikh at Yale, and now he's chief at Hopkins, he had this ASSESS-AKI consortium. It's been 14 years now using these data. Multiple centers, cardiac surgery. There was adults at these centers enrolled. They have pre-op and post-operative blood and urine collection. And we've published a lot on AKI and then subsequent cardiovascular events and death long-term. But one thing we have not done until just this past 6 months to a year was look at CKD, because it was actually tough because people get referred in for cardiac surgery. Getting all the creatinines longitudinally was tough, but we finally managed it. We got a 943 of the 1219. And we just presented this last week in Washington, D.C. at our ASN Kidney Week. We measured 40 biomarkers now in TRIBE, several plasma and several urinary biomarkers. Tough to read here, but they're all on the bottom. The interleukins, proBNP, troponins, et cetera, et cetera. And again, I mean, it's not completely unbiased, but look at the 3 strongest markers again. This is pre-operative blood sample, adjusted for everything that happens during the hospitalization, with CKD outcomes 5 years after the surgery. So there's something in the protoplasm of these patients they're at high risk. We also, I mentioned the ASSESS-AKI cohort before. This was a 10-year consortium that just ended. We were part of it at UCSF, Vanderbilt, Washington. So this study was looking at patients with and without AKI and looking at long-term follow-up. And the 3-month visit was actually the baseline anchor visit and then subsequent follow-up. And here are the TNF receptors measured at the 3-month post-hospitalization visit. You can see per doubling these biomarkers, and here are the quartiles and your risk of progression, of CKD progression in this cohort. And this is adjusted for all these variables, including the GFR at that time, the UACR at that time, whether or not they had AKI, whether they had CKD before admission. And another thing here was the 3-month C-reactive protein. Because everybody says, well, you're just picking up inflammation with the TNF receptor. Yeah?
Biology.
Mm-hmm.
You have mentioned transforming growth factor beta.
Yeah.
Beta 1, and
Yeah.
there is evidence, I guess, over the years that it's involved in
I know.
Inflammation. So I was wondering whether it's something that you are ignoring, not
Yeah,
feel.
sure. Yeah, that's a great question. We had it as one of the markers in my Cohort grant application. The problem is the assay is very difficult. There's this whole platelet degranulation issue, the free versus the bound. So we had problems with the assay. And then it wasn't just me in our lab. There was one paper that showed this amazing association in the advanced cohort. Advanced, remember, with advanced and cohort were contemporaneous. As part of CKD Biocon, we went through this whole vetting of which biomarkers we're going to measure, numerous plasma and urine biomarkers. Also, the Harvard lab, Joe Bonventure's lab, they have a preeminent lab. They couldn't get the assay to perform biopsy either. So biologically, at the tissue level is great, but measuring it as a clinically useful biomarker is difficult because of all the noise. A great question. Oh, why does this keep going back? Okay, my alignment's back. Shit. So GFR is up here, the point estimate is there, albumin and creatinine, C-reactive protein, and here's the per doubling in the TNF receptor. So head to head, again, these are giving you some additional signal. Children, I actually cut this part out. I don't think, are you guys interested? It was GNs and CACA, only Ferd is interested. By the way, welcome Ferd, Ferrer. He's a new pediatric urologist here at Mount Sinai. I just joined like 2 weeks ago, and we're hoping we can collaborate, but he's nice enough to join us. We are, for sure. So I'll just tell you, it worked here too in kids with GN and urologic anatomic abnormalities, urinary tract, these 3 biomarkers. So I'll get to this. I want to save time for more questions and cut out the 10 slides I had on that. I'm trying to make a hold on, before I get to this. You know, does anyone read the 538 blog? Like Nate Silver? Nate Silver predicts these elections like tremendously, although he's wrong. Right? You know, who knows Nate Silver? Come on, Nate. You know what I'm talking about? If anyone reads this blog, go on, it's amazing. They do all this, whether it's politics, sports, economics, they have this amazing data visualization crew. They show you one shot and you can gather the whole story. And I can't do it, but I've been begging my statisticians and programmers, please make me one money shot, because this is the crap I come up with, a stupid forest plot that looks very ugly, trying to summarize all the data. This is Kim one, right? Ugly. So then I tried playing with Tableau. Anybody ever use Tableau? I got some free trial. Again, I'm a klutz with this. And this is like a stupid bar graph is the best I can make of the number of published studies, and then the pooled adjusted hazard ratio for the biomarkers. Remember, I cut out the data on SUPAR and FGF23. Why? Because A, it's weaker and it's less studied. So then I saw this summer. I showed you that with this ASSESS-AKI. Bupkis. You want me to go back? Horrible. Anyway, you guys saw that, right? CRP didn't work. That's what I liked about the ASSESS data. We adjusted for CRP. So then I saw this amazing shot in Time magazine, the 50th anniversary of Apollo 11. And they had the moon in the middle, and they had all the missions that made it, to the atmosphere, to lunar orbit, landed, and now it's getting to the middle. And then I sent it to my programmer in Colombia, like the country. And I said, make me one for biomarkers. And here we've got the adjusted hazard ratio is stronger the more you go in to the center, okay? I don't know. Do you guys, I need to label it better, everything. We've got TNF receptors 1 up here, R1. It needs better color discrimination too. R2 is here, and KIM1 is here. I don't know. It doesn't do justice. So then my statistician Kinsuk, he tried with Excel. Here's the adjusted effect size now. Obviously higher is better. Here's the different biomarkers, all the different cohort studies. I still have not found the money shot. So if there's anyone out there, I'll pay you. I want a money shot of the density times the strength of the whole landscape of published biomarkers for this use case for prediction of CKD progression.
What about urinary microalbumin creatinine ratios? Where is that in here?
We adjust. This is on top of it, and that is why the urinary biomarkers I skipped, because there's a common story. Yes, KIM1 or use signal, but once you adjust for urine albumin, the urinary biomarkers do not add to the AUC, do not have an independent adjusted hazard ratio. But these are all adjusted for urine albumin, and these are the adjusted effect size for baseline GFR, UACR, and blah 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 blah, blood pressure, A1C, etc. So it's above and beyond. And I think that's the metric. You have to beat urine albumin, or else you don't have a useful biomarker.
But increasing urinary microalbumin does.
Of course.
Yeah.
Yes. Yes.
Okay,
But there were also people. Sorry, no, go ahead.
Once upon a time, there was a vote for looking at protein kinase C as being the end step after urinary microalbumin. There was even a drug trial.
Yeah.
Inhibition of
Yeah, I remember.
protein
Yeah.
C. How does that?
But is there a good, reliable assay for that? No, there's not. It's biologically, again, in the tissues it's happening, but not a good, my goal, look, I'm not a basic scientist. I've never touched an animal, well, I mean, except for my dog. I never touched a mouse, except the dead ones in my yard. So I don't go deep on the tissue mechanism. I told you my goals are to enrich clinical trials, which we're going to get to, and to change clinical practice. So they have to beat albumin, and they have to be a reliable assay across patient settings and across handling practice, etc. Oh, here we are, the goals, right? So let's get to this. I think I'm going to have to blow my nose. You guys are never going to forget me. All right, let's start. So, okay, you talk about albumin. Here's the current state of affairs in nephrology. KDIGO heat map. GFR, albuminuria, color-coded for your risk of progression to end-stage kidney disease, okay? So you've got the red, orange, yellow, green. Oh, what I wanted to tell you here for the enrichment. So trials have used this, and clinically we're going to use this, and I'll talk about it, to say, let's bring in these people into the various trials. And that's where these next 3 trials took patients from. The boxes with some enrichment, right? They're not pulling the red beds because those are too late. You're not going to impact upon fibrosis there. So you're taking patients with stage 1 through 3 with at least some albuminuria, or stage 3 GFR. So I mentioned Nephron D before. What happened in Nephron D? Dual RAS blockade was not statistically significantly better than monotherapy. I mean, it almost was, but it wasn't. And we've largely given up dual RAS blockade. Look at the methods of VA Nephron D. 51% of expected event rate at 3 years, thanks to being lean. 20% observed. That's bad, right? This is like planning your wedding without finding your spouse yet when you're designing a big trial, right? The SONAR trial, you guys familiar with SONAR? SONAR was published in Lancet this spring. It was released the same exact day, the same exact hour as Credence, which we'll talk about in a second. So nobody's remembering SONAR, poor guys. Atrasentan and the endothelin antagonist. Here's some of the methods. They needed 425 events for a 27% risk reduction. After all the patients were assigned, rate of outcome was lower, blah, 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 doo-doo-doo. They only got 184. Well, that sucks. Because here's a plot of it. This is where they stopped the trial. This is the events they got. They wanted that here. Remember, they enrolled off the heat map. They did actually 25 to 75 with at least macroalbuminuria. So we have Credence. I have a whole talk on SGLT2 inhibitors. You guys are probably all over it, though, I hope. GFR 3090 with at least macroalbuminuria. We're not supposed to say macro anymore. It's like high albuminuria now. Why is my alignment screwed up? Anyway, the problem with, I've been pounding the table on the SGLT2 inhibitors. Canvas and Pareg and declared to me 1858 all enrolled patients from here on the heat map. Credence was cool because GFR was 56, a gram of albuminuria. They were from here, and they got a lot more. They got a lot more dialysis events, 176 versus the previous SGLT2 inhibitor trials, which were mostly CVOT trials and not DKD trials. David Lee, by the way. Anyway. So this was presented an hour later, right after SONAR, not even the same hour, at World Congress of Nephrology in Melbourne. And you guys know hazard ratio 0.66 for the renal outcome. I mean, we haven't had anything like this in years. This is fantastic. Not since ARBs and IDNT and Renal in 2001. But here's the thing. Credence came the closest, but they all slightly observed versus what they expected. So how can you enrich for more events? Look, I told you that the association of these biomarkers, you know, everybody throws around personalized, oh, here's David. Personalized and precision medicine. Yeah, it's all smoke and mirrors, right? I'm not arguing for that. Don't buy, I'm not snake oil selling you. I'm just saying, can we better stratify patients up front? And can we better stratify them off the heat map? Because the heat map, we're going to get them in those big 3 trials by world-class investigators. So just, can we put them into better buckets? Again, here's like the SONAR trial. We got way lower events than expected. You enrich for higher event rate. Oh, God, my alignment. This curve goes up here. You get more events. It's not necessarily predictive of therapeutic response. Just get more events so you don't have a type 2 error. And you could do this for various, whether it's diabetes, APOL1, or other kidney disease. Do some profiling with either blood biomarkers and a risk score and enroll those. Don't waste your time, resources, money, whatever, on these people. You're only going to sacrifice, you're not going to see a signal, and then they're only exposed to the potential adverse effects from your new drug. So I've showed you this before, 0 through 3 biomarkers elevated. Focus on where the events are instead of enrolling these people. Same with the APOL1 story, right? So we developed this calculator online. This is with Chirag and then 2 cancer biostatisticians at University of Washington. It's called BioPet, Biomarker Prognostic Enrichment Tool. You can go, I think I have the website on the next page. Like, for example, if you take Credence, which had a 15% baseline event rate, they presume, you know, they got a 34% reduction, but they assumed 20% because they didn't know up front, and that's a reasonable effect size. So you put in 15% here, 20% risk, you put your alpha, beta. Then you put in your AUC of your risk score, or your biomarker. So I put in 0.8, because that's where we're getting to in a second. And I put $1,500 to screen and $40,000 to run through. I don't know how accurate those are, but it's close enough for this example. So here's what credence needed: 4,400 patients, because that's what they powered it for. If my assumptions are whatever, 177 million. You think I'm in the ballpark there? What you do is, if you already have a profile population, here we have BioMe, there's a lot of biobanks out there, can you say, all right, don't bring all these patients in for screening visits, let's just pull at the top 35% or the top 20%. You now get an event rate of 30 to 40%. You have to screen more people, fine, but screening's a lot cheaper than running through. You only need 1,200 patients, and you'd saved a ton of money. And on the third tab of the website, we have the curves about your event rate among the positive patients, your sample size needed, number needed to screen, and your percent reduction in total cost. So you guys can play with that. And we actually are in beta testing for another one where you actually have, because this is just yes, no for outcomes, we have time to event, and you can look at the survival curves with enrichment. Ah, forget it. Okay, so I think, well, you guys can tell me. I think these markers can enrich because you're getting additions. Yeah.
The risk ratio is double
For which one?
when you enrich population. How high a risk ratio in your enriched population?
The event rate. It's the event rate that's changing. You're getting, instead of 15% events, which is what they got in credence, if you took a profiled population with biomarkers, you could say, I want there to be 30 or 40% events. Oh yeah, doubling the event rate. Yeah.
So
Your baseline risk is doubled. Intervention
the
of the
number of events you're going to get in the trial is double.
double. Yeah.
Right. So why doesn't it just come up with cost of the trial?
Why is it just half the cost? Oh, well, this one's closer to half. At true doubling, here I went to 41%. So you're like 2.5 times.
So it really depends on how well you enrich.
Yeah, but eventually, there's a downward, if you screen so many people, then you eventually reach an inflection point, you go on the down slope of the curve. We've been trying to entice multiple pharma companies with this, and there's been a lot of flirting and dancing, but you know, the true, one of the rebuttals they give us is then you're going to limit our market share.
That's the dilemma with credence. If you really look at it, I might just put it a commentary on this, that credence really is applicable only to 5% of diabetes, which is, those are a very important subset of the diabetic population. But we can't then go and say everybody with diabetes and CKD needs to construct together, because this is a totally different population.
Except if you take then, extrapolate then EMPA-REG and Canvas, which were low risk, non-CKD, it also worked there.
Well, those are different high-risk populations. People are, I mean, I'm using these drugs. You know, everybody walks in the door.
Yeah.
But it's
small.
a big stretch to go from these high cardiovascular risk or renal risk to then, you know, so this table is fine. It's useful, and if you know, J&J decided to do this very focused study, but you notice they're getting out of the diabetes. So.
Oh, I know, this is not for SGLT2. Now this should be for the next blockbuster drug that someone has, realizing that if they don't want to spend the money on 4,000. But yes, they would potentially limit their label for their indicated use population. So that's why it's been a struggle to actually ink a deal. We may do some post-hoc analyses of the trials. Okay, clinical, let's get to it. I'm still congested. So this whole talk was supposed to be about machine learning too. This is what we see when we see a patient or a primary care physician or whoever sees a patient. They see all the numbers. Obviously, the kidney controls pretty much every electrolyte and metabolic process, so everything goes awry. And then maybe, remember my slide with only 40% referrals, maybe there's paralysis by analysis, right? People just get overwhelmed, can't deal with all these numbers, and they're like, whatever. how do you integrate all of these things, including albumin and slope and everything. And so you can't run just a regular logistic or Cox model. You need a machine learning model. It's not a clean, in clinical practice, you don't have clean visits like this, like in a cohort study with annual follow-up or Q4, whatever it was. And you have all these missing gaps, and this is just GFR and albuminuria. Imagine everything else, right? So you try to run these random forests, which take all these, branch everybody into these trees and create these nodes and branch them off. It can test all these interactions at different cut points. And so that's what we started doing, taking in the clinical variables, using the biomarkers, creating a risk score, locking the data there, and then looking forward for kidney endpoints. And first we did it in BioMe. These are some of the variables we considered. And the variables go in, and then you not only have the raw variable like the serum potassium, you can also create the features. So the feature can be the min, max, the slope, whatever. And how much that adds, questionable, but it's not just the raw features themselves. You train, test, and validate it, and that's what we've been doing with our data science group. And we published this online from the original BioMe. I showed you the 871, the ones I initially pulled from BioMe, and just showed you initially I showed you Kaplan-Meiers and Cox models. Here it is with just the clinical model alone, including albuminuria, biomarkers alone, doing machine learning, random forest on just the clinical variables, and then the combination. And this is in the 20% test, which ended up only being like 160 patients, so kind of small numbers, which is why we went to multi-center validation, which I'll show you in a second. This is a plot we have of your risk score and then your risk of the outcome. You can see about a third of the population is down here with low risk, and they have a negative predictive value of 97%. So only 3% of that low risk group progressed over 5 years. In the high risk group, probably end up cutting this at 15 or 20% instead of the weird 18%, but you get a positive predictive value of 53% if you have a predicted risk over 25%. So you can tell your patient you have over a 50-50 chance of progressing over the next 5 years. You should be referred, consider SGLT2s or better blood pressure control, maximal ACE-ARB, etc. Here are the GFR slopes by risk group and the high risk progressing to ESRD. Here's the Kaplan-Meier curves by risk group for the endpoint. And nephrology, we've been, somewhat dinosaurs in this, cardiology, oncology, doing all this, gene expression panels, this and that, tailoring things, and granted, we haven't had the therapies. But the community, this was from last year's ASN, Mark Akusa, who's a classic transport physiologist from Yale and chief chair of medicine at the University of Virginia. He talked about using machine learning. Eric Topol, if you guys follow him on Twitter or his books or whatever, he's been blowing this up, saying we need to leverage all the data. And so that's what we have set out to do, incorporating these biomarkers and the clinical data, creating this random forest or machine learned risk score, and then the goal is to deliver it to the physicians and to the patients so that awareness improves and clinical management improves. And that's what we call Kidneylntelx, doing this, incorporating it, again, the risk score. And we got breakthrough designation from the FDA in May, and then so they're going to help us develop it and bring it to approval. And what we needed to do, and what we're working on now with the FDA, is going from that initial pilot or first study we did with the 871. We also did the same for APOL1. I just didn't show you the data on the random forest. But now doing it with, we got adequate performance there, now doing it with multi-center, and we got a couple thousand samples from UPenn and from Emory. They're both cardiovascular biobanks, whereas Sinai's BioMe is more outpatient primary care. But again, we're in the thrust of it. Here's the heat map again for reminder of where you could put patients. Our indicated use population is precisely those in these blue boxes. We don't want to screen patients here. They're very low risk to begin with. We want to add additional risk stratification onto people that may go either way on the fork of the road. We are not going to test people with stage 4 or stage 5. They should be in the hands of the nephrologist. They should be talking about renal replacement options. They're too close. So it's these stage 3, regardless of albuminuria, or stage 1 and 2 with some degree of albuminuria. So if you use the heat map, this is what we're getting from the validation study, like we're in the midst of it right now. These are hot off the presses. Here's what the percentage of population that falls into those color-coded boxes, and here's your risk for the kidney outcome, which is a composite of rapid kidney function decline, GFR decline over 5 milliliters per minute per year, 40% decline sustained or dialysis or transplant, 16, 26, 33. If we stratify Kidneylntelx about the same groupings, we can get very low risk, 5% risk in the majority of the population, and again, above 50% risk in the high-risk group. Here's the continuum of the risk score, low, medium, high. And again, you have like tenfold. Here's the top decile now. The reason that was 58 before, because it's averaging, it's taking half of this group. Oops. Half of the 9th decile, right, at 50%.
How it's computed. What are the components of kidney?
So I showed you all the inputs. Then the top features are the biomarkers. We actually did ratios of the biomarkers, eGFR, albuminuria, A1C is in there, and a bunch of other chemistries. But then there's these weights applied to them through the random forest. It becomes slightly black boxy, but not completely, because we can see the most important features. We do this uplift curve. And so largely it is the lab, A1C, I told you A1C is in there. It's largely the lab-derived variables that contribute to the performance of the test. Ultimately, there'll be a light version where people who are not completely integrated with the EMR will give the 15 to 20 important variables that we finally locked down, which we're doing with FDA right now. But there'll be a complete enterprise version with Sinai and other places that do agree to the data sharing, where the data is going to come across the firewall into the Azure secure cloud. And then all those features, again, interactions that are being tested that you cannot do with regular modeling.
Years ago, this was looked at very intensively with diabetes.
Yep.
And it turned, Michael Stern from San Antonio did a lot of this work. It turns out that if you look at clinical variables like family history, body mass index, waist circumference, and so on, it totally trumps a lot of these other variables. I'm not saying that would work.
Yeah, BMI is in here. Family history is wishy-washy.
Family history is super important clinically. I don't know whether you've tried to look at whether there are non-laboratory variables.
Well, we've considered all of these. We're running unsupervised, letting it pick the top performing variable.
And so the family history was not
True. Yes.
How does compliance factor into this? Like showing up for clinic visits, taking your meds, bill count and stuff like that.
Well, compliance is half the problem. I showed you again in the first few slides, awareness of kidney disease, especially stages 1 through 3, is less than 20%. It's actually like 10% in those stages. And at stage 4, only about 45% are aware. So we hope this serves as somewhat of a motivating factor on both ends. This is going to be it's a mock-up of the report. We need to finalize it. This needs to be put into Epic or put into the EMR for the other centers that sign up. You get the results like your FICO credit score. You're going to get your kidney risk score. You'll be given a categorical low, medium, high, and a numerical score with an explanation here. And we hope this does drive compliance. And we hope currently the KDIGO guidelines say, here's normal people, diabetes, right? Here's people with stage 4 or macroalbuminuria, they should be referred. That's what the KDIGO guidelines currently say. But there's this group with the GFR less than 60 and albuminuria 30 to 300. if we map this to NHANES, 70% of DKD, which is about 12 million patients of the 38 million with type 2 diabetes, fit in here. And currently the guidelines, at least the kidney guidelines, KDIGO, say do not refer, just monitor. But we can pick out, I showed you the 15% who are at risk, 50% risk for progression. That is what we're hoping to do, is to drive this and get people in here. And the rest can continue to be monitored.
How about predictions within microalbuminuria?
Albuminuria is one of the most important variables in the features in the random forest. It consistently is in the top 1 or 2, depending on whichever model we run.
But if you're below macro, but in the upper range of macro, does that add to it?
Or is it more about, I mean, obviously one would think it's more about the progression. You know, we all see these patients that come in, their microalbumin is 40 or 50.
Yeah.
You know, they've had nothing before. You throw them on an ACE, you throw them on an ARB. Keep your fingers crossed, their blood pressure's reasonable. They repeat it, they're negative. You don't know. They come back the next time.
Yeah.
They're about in the same range. And some of those progress and some don't.
Right, and that's where these other
They're giving
biomarkers
this information.
that I've shown you from 20 other papers have additional signal. Whatever the TNF receptors are doing at the tissue level, we don't know how causal it is or just a good marker, but they're reliably giving you an extra signal on top of any cut point of albuminuria. And the random forests are finding the optimal cut points of albuminuria within all the spectrum. So again, here's 12 to 15 million. You find these high-risk people who have over a 50% chance of progressing. Leave these people alone. I'm telling you, when I'm at the clinic at 102nd Street, yeah, half the people have a GFR of 20 and have never been told, and then they're crying when we tell them we got to talk about a fistula and this and that, or home PD. Like, oh my God, I didn't know. Then there's another group, I don't know what exact percentage, being referred with like a GFR of 59, no albuminuria, and we get these referrals from PCP saying check their kidneys. Such stuff. And then the fellows, I got no offense, fellows, they're rebooking them for 3 months. I said, what are you doing? They're so low risk. And I know why. You can only max out at 8. Next time, it's such a quick, they're out by 3:30, 3:15. So, no offense, fellas. Don't listen. Check what they're doing. Okay, so look, so what we say is, yeah, can we match? And we're talking to Janssen, J&J about collaborating and measuring some samples from Canvas. Is there a group here that should be on SGLT2 inhibitors? Can we expand that population? And then once they're in the system, again, this lack of referral, you don't have to have the devastating, oh my God, I'm crying because you got to go straight to transplant or dialysis. They're now in your system. You've been talking to them for years, and we can likely shift more people to home therapies, which is the big, Lord say, don't say his name, presidential mandate to shift more people to home therapies, right? They want like 80% home therapy by 2030. It's all Alex Azar. I don't think the person above him knows where the kidneys are. As a matter of fact, he said the kidneys are in the center of the heart. So, but look, all of this is nice on paper. The retrospective validation will be fine for FDA. That's what we're doing with FDA. But we need to ultimately get reimbursement and to prove to the community it works. This has to be randomized in a clinical trial to see the difference. Are you guys gonna? Hey, David. David's gonna be the PI of the trial, so that's random. We'll get them at the clinic, get the samples, run the score, but give the score to half or some unbalanced. We're still trying to decide that. They get the score. Are things going to change? Are more appropriate people going to be referred to nephrology? Are medications going to be more appropriate? Is albuminuria and GFR going to come down? Albuminuria going to come down, GFR stabilize, and then long-term outcomes. And we're also creating this portal for the physicians. I know you guys don't want to log into a second place, but there's going to be care managers, and Barbara hired one person already, and there may be more. We're going to sit at a dashboard-like level, tracking people of where they're going, because it is crushing the healthcare system and Sinai's system of the costs and such for CKD. And so people can follow their risk score, they'll see the components of what drives it, and we'll have recommendations here. This is still in progress. Okay, so, and then the last thing, SGLT2, I mean, you guys have known, everything's reducing the outcome, whether it's been overt DKD in credence or the high cardiovascular risk groups in the other 3 trials. And, then when I present solely on SGLT2 inhibitors, everybody's worried about, there was double the amputation risk in Canvas. People worried about dehydration, especially if they start with a high A1C. Or 4 years there's been reports of 55 cases, and they were reported in the annals, no control group. There's a small but increased risk of DKA, euglycemic DKA, right guys? But then you've got all the benefits. So how do you weigh this? I mean, at my simplistic ivory tower view, I still think this outweighs, but I'm 80% research and don't see that many patients. People are worried about this, especially if they see a picture of 4 years. They'll probably have to peel them, they'll be hanging from the pipes there. They'll say, come down, don't worry, but nobody wants to lose that, So you can tell them you're not going to be on dialysis, but they'll say, people take Viagra with critical coronary artery disease. They don't care. So how can we do this? There's this concern, can you risk stratify patients better? This can just help tip the conversation which way you want to go. Less risk? Well, maybe you don't. You don't really fit the indicated use for credence and this. But then if they are high risk, let's talk about it. And again, there's ongoing work with bank samples from Canvas and then credence that will hopefully answer this. Can we interplay with the SGLT2? And then that's not only setting it up at baseline, can the biomarkers change over time? Because let me just show you this. This was from Cantana SU, the trial before Canvas. They looked at several biomarkers in different pathways, inflammation, growth factors, matrix, and signaling. They pulled down 10 of them, measured them, and the biomarker that changed in response to canagliflozin that predicted the ultimate GFR decline was a change in TNF receptor 1. If you came down, your GFR stayed stable. And if your TNF receptor went up from baseline of 1 year, your GFR dropped the most. So there's some potential pharmacodynamic effect there. We'll be testing the whole Kidneylntelx package. But are you guys worried about this at all? Obviously, from the effects of tubular glomerular feedback, constrict the afferent arteriole, you are getting some initial drop in GFR. This has been seen in all the trials, either the early stage with Canvas, infrared, or with credence. And, it may not be everybody, but someone say, oh, your creatinine's up now. The patient's going to screw it. I don't care about the long term. I only care about what's happening now. Can we use biomarkers or Kidneylntelx composite risk score to guide people through this initial GFR decline? Because it's the marathon, not the 100-meter dash that matters. But you've got to wait for that stabilization crossover. So anyway, I think we've reached a tipping point in regards to all the data that's out there as far as being able to prognosticate risk above and beyond clinical variables. And I think it's time really to get patients into the right place, seeing the nephrologist if they need it, starting SGLT2 inhibitors if you haven't already in the high risk, etc. So I think we can change that dismal graph in the beginning of ESRD and lack of referral. And so thank you to all my collaborators, and thank you guys for your attention.